Bueno, pues nos ponemos en marcha, Tenemos una semana por delante apasionante. Por favor, no se olviden, vayan tomando nota, va a ir apareciendo en pantalla en nuestro canal YouTube el teléfono de OAFI para que ustedes se informen cómo poderse asociar, cómo poder ser voluntarios, cómo poder participar en los diferentes ensayos clínicos que estamos realizando, sobre todo con la intención de mejorar la calidad de vida de todos los pacientes que tienen problemas osteoarticulares, artrosis, osteoporosis, aunque vamos a centrarnos también en el mundo del deporte, pero no podemos desligar lo uno del otro, igual que tampoco podemos desligar la investigación. Por eso vamos a empezar este congreso con una entrevista que hace escasas horas grababa nuestro presidente, el doctor Josep Vergés, al que han visto ahora mismo inaugurando este congreso, pero agendas del profesor Ali Mobasheri nos ha obligado a grabar esta entrevista. Nos parece apasionante e interesante. El profesor Mobasheri es el presidente de la OAFI. La OAFI es la organización, la Asociación de Investigación Mundial de las Patologías de Artrosis. Así que es una persona que es además un gran colaborador, un gran amigo de OAFI, y hemos querido que estuviera presente en esta jornada inaugural de este primer simposium articulando el deporte, porque también la OAFI, evidentemente, es una organización amiga y a la que le damos la bienvenida. Esta es la grabación, esta es la charla apasionante que han mantenido hace escasas horas el doctor Vergés y el profesor Mobasheri. La vemos.
Gracias, Ricardo, por la presentación. Bueno, hoy tenemos un gran profesor, que es el profesor Ali Mobasheri, presidente de la OAFI. Thank you very much, Professor Ali Mobasheri, to stay with us in our Congress, the Congress the first Congress in sport medicine, that we are organizing with National Committee, Olympic Committee, Spanish Olympic Committee, Fundación Atlético de Madrid, and medical services from Atlético de Madrid. It's a great pleasure. And Ali Mobasheri, he has a very important background. Ali Mobasheri is actual president of the Osteoarthritis Society International. That is the society that is making the best research in the world in basic and clinical research in osteoarthritis. And also is a professor of musculoskeletal biology, is professor of musculoskeletal biology in the research unit of medical imaging, physics and technology with the Faculty of Medicine, University of Oulu in Finland. Ali holds the position in chief research in the State Research Institute Center for Innovative Medicine in Vilnius, Lithuania, and is an associate professor in the Department of Orthopedics in the Department of Rheumatology and Clinical Immunology at the University of Medical Center, Utrecht in the Netherlands. Visiting professor in Harvard University in Boston, USA, and visiting professor Sanyat in University, Kundan, China. Ali was educated at Dulwich College London, Imperial College London, the University of Toronto and the University of Oxford, where he obtained his doctorate from Wolfson College, Oxford. He ranked as one of the top 10 leading experts in the world on osteoarthritis. He's a great expert. That means that we are very happy, Ali, that you stay with us in our Congress. For us, it's a great honor to have your participation here. Your speech is Research in Sport Medicine and Osteoarthritis, Connecting the Dots and Filling the Gaps. Go ahead, Ali, when you want.
Thank you. Hello, everyone. Buenas tardes a todos. I hope everyone is well and looking forward to have a very productive afternoon. In this session, I was asked to talk about sports and linked to osteoarthritis, what's being done in sports medicine. And there are some interesting opportunities for research to fill in the gaps, but as you might imagine, in a multidisciplinary area such as this, there are also lots of opportunities for connecting the dots and bringing people together from diverse backgrounds. Thank you, Giuseppe, for the very kind introduction. It's a great pleasure for me to participate and share some of my thoughts with you. So before I begin my presentation, I'd like to deal with some myths and some fake news. Let's bust the myths and expose the fake news. Osteoarthritis is a wear and tear disease. No, it is not. Running causes osteoarthritis. No, absolutely not. Exercise makes your knees and your articular cartilage wear out. No, 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 absolutely not. And of course, it is true that traumatic injuries such as cruciate ligament tears and meniscal tears can increase the risk of development of osteoarthritis. But if these injuries occur, they increase your risk of development of osteoarthritis. It doesn't mean you stop using your joint. So I think it's very important to continue walking, cycling, swimming, jogging, whatever you can do to continue doing that, not just because of the joint, but because of overall health of other body systems. And I'll return to that concept at the end of my talk. So if you think about our concept of osteoarthritis for many decades was viewed as a disease of articular cartilage. We really have left that behind, and we now look at osteoarthritis as a disease of the whole joint, and increasingly as a disease of the whole person. And some people don't like the term disease. Some people like to call it a disorder, but ultimately, with any definition, is perturbation to normal physiology, leading to changes that could cause pathophysiological alteration in joint tissues that basically results in the syndrome of osteoarthritis. Of course, systemic factors are influencing disease development, such as age, the #1 risk factor, obesity, the female gender, physical inactivity, and of course, genetic predisposition. And then there are, of course, environmental and mechanical factors. Obesity is at the top of that because it's excess weight and it's excess white adipose tissue, white fat. Morphology of the joint, malalignment potentially, loading of the joint, abnormal loads on a normal joint or normal loads on an abnormal joint, some of the terminology that's been proposed roughly 10 years ago by Nancy Lane and colleagues. And of course, you get osteoarthritis, and then a vicious cycle begins accentuating the comorbidities, diabetes, hypertension, and pain is what the patients feel, depression, anxiety, lack of sleep, and ultimately pain and pain sensitization. Physical inactivity is one of the key components of the symptoms that patients feel and the structural pathophysiology. So pain, behavioral changes, the psychological distress, and the disability associated with osteoarthritis has lots of different components, but ultimately it's physical activity and inactivity that play a very important role in disease development and how we manage it. So we know that aging, being overweight, and the lifestyle choices that we make are important for the development of this concept of inflammaging, which is commonplace in modern society. And inflammaging causes disease. And in the joints, it can cause early senescence of joint cells and tissues, and what we have previously defined as, within articular cartilage at least, chondrosenescence. So these are the contributing factors: obesity, being overweight, lifestyle choices, poor diets, contributing to excess weight, to physical inactivity, and inflammaging. But when we think about evidence, medical evidence, these are the typical pyramids that are used to show that at the very top of the pyramid, we have the strongest evidence, which is systematic reviews and meta-analyses. And further down, you have randomized controlled trials, cohort studies, case control studies, case studies, and really a lot of the stuff that we do as researchers. I'm an in vitro researcher as well, working with in vitro models, with preclinical models, really is at the bottom of this pyramid. And many of the papers refer to this as low quality evidence. But let me put the question to you this way. If we define it as low quality evidence, it is the foundation for the pyramid. So if you build anything with a weak foundation, it's going to crumble down. So we have to really accept that, yes, systematic reviews are important, but a lot of the work that's being done with animal models, with translational models, with in vitro models also contribute to the science that we will then translate for the benefit of patients and the public. So let's focus on the top, because I have limited time. Let's focus on systematic reviews. This systematic review was published in 2013, and it looked at exercise for lower limb osteoarthritis, and it was a systematic review incorporating trial sequential analysis and network meta-analysis by a group in the UK, and also by collaborators in the United States. So what was the previous knowledge on the topic? International guidelines for osteoarthritis treatment and management at the time recommended therapeutic exercises, land and water-based, as core for the effective management of osteoarthritis, providing benefits of exercise for pain and improved function. What this study added to the knowledge at that time was that there was enough evidence to show the significant benefit of exercise interventions versus no exercise in lower limb osteoarthritis, meaning, for example, the knee, indicating that further trials of exercise versus no exercise were unlikely to overturn this positive result. And evidence for the network meta-analysis that was done largely in knee osteoarthritis indicated that programs of exercise combining flexibility, strengthening, aerobic exercises really are able to control pain and function. So that's the critical thing. Any new evidence is unlikely to overturn pre-existing evidence. Then a group from Australia published this systematic review, Exercise for Osteoarthritis of the Knee. They did a Cochrane systematic review and published this in the BMJ. And they proposed that high quality evidence suggests land-based exercises provide benefits in terms of pain and improved quality of function. And any kind of exercise program that's performed regularly and closely monitored, hopefully with the help of a healthcare practitioner, with the involvement of a physiotherapist, can improve pain, improve symptoms, and enhance physical function, and enhance the quality of the life of the patients. So the magnitude of the immediate treatment effects of exercise on pain and function increases with the number of face-to-face contact occasions with that healthcare professional, reinforcing the fact that a healthcare professional really is very important to enforce the positive messaging and to keep monitoring. So you, to a certain extent, especially now in the COVID pandemic, patients with arthritic diseases have had to manage their own condition. But of course, as the vaccination progresses and we see more of the society opening up, we really look forward to meeting our healthcare professional and moving to a face-to-face meeting with them rather than on Zoom or on the telephone. So that interaction is really, really important. But of course, as with many other systematic reviews and synthesis of the literature, there is quite a lot of the variability in the data. And this lovely systematic review protocol designed by Wei Zhang and colleagues at the University of Nottingham highlighted some of these issues. So they designed a study to look at exercise as a universally recommended core treatment for hip and knee osteoarthritis, highlighting the fact that there are very few head-to-head comparative trials to determine relative efficacy between the different types of exercise. So what type of exercise is good? Land-based or water-based, a combination of these things. So there's quite a lot of additional data that we can glean from further studies in this area. So the aim of their study was to benchmark different types of exercise against each other through use of a common comparator net and a network meta-analysis of all the randomized control trials that were done in this area. So they published their study several years later in Annals of Physical and Rehabilitation Medicine. So this is the systematic review, and I won't go through all the details. They did look at a very large number of papers, and they were able to show there's quite a lot of there's quite significant variation in the literature in terms of trials that were showing benefits and pain improvements, and some of the trials were showing really quite significant pain improvement. So what is it about those trials? What is it about those approaches? So they looked at pain, they looked at function, they looked at physical performance and quality of life. And what they did, they actually provided the synthesis of all the trials that were done up to that point. And they were able to show that for all of these parameters, pain, function, performance, and quality of life, exercise improves the patient's situation. So the meta-analysis compared efficacy of all types of exercise versus usual care for 4 important knee and hip osteoarthritis outcomes. And the results showed that at 8 weeks, exercise had significant moderate benefits for pain and function. Effects often built up to 2 months and then gradually decreased by 9 to 18 months when the exercise was withdrawn. It basically suggests that for a number of months, you will gain pain benefits by having exercised, but the best benefit is when you continue to adhere to that exercise regime. In 2019, Virginia Krause and colleagues published this paper in the American College of Sports Medicine. This is the official journal. They looked at the effects of physical activity in knee and hip osteoarthritis. They did what's called a systematic umbrella review. And they looked at land-based exercises. They selected a smaller number of studies looking at pain, physical function, and quality of life. And of course, for all of these, they were able to show that it basically favors exercise, these enhancements. And the same was observed with aquatic exercises, looking at pain, physical function, and quality of life. So exercise has a beneficial impact on the patient. Physical activity decreases pain, it improves physical function, it improves quality of life among people with hip and knee osteoarthritis relative to less active adults with osteoarthritis. So the strength of the evidence was very significant. 261 studies of various physical activities, modes of exposure, land versus aquatic exercise. And they were able to propose that there's no evidence at the present time to suggest accelerated progression of osteoarthritis in individuals with pre-existing joint conditions when you have below 10,000 steps per day. Now, I know that's an arbitrary number, and it goes back to studies done in Japan in the 60s, I believe. So we really need to move away from the 10,000 steps per day and individualize exercise, personalize exercise for osteoarthritis patients. Nevertheless, exercising for at least 45 minutes per week, and this is a really modest proposition, can improve and sustain function of joints in individuals with lower extremity osteoarthritis. But of course, we want to exceed those limits. This lovely review was published in August 2020, looking at core and adjunctive interventions for osteoarthritis. And they were able to put together all the current treatments and all the possible treatments. For example, looking at wider issues in osteoarthritis, muscle weakness, for example, and some of the things that we haven't really thought about in sufficient detail over the years. Mood and quality of sleep. So when you think about all the possible treatments that are available, education, self-management, physical activity, maintaining a healthy body weight, these are core treatments as indicated by these blue circles. But in terms of adjunctive treatments, cognitive behavioral therapy, bracing, providing orthotics, and pacing and walking aids can also bring significant benefits to specific osteoarthritis issues rather. And when they compared all the different treatments that are available, you can clearly see, and this is really an important take-home message. At the bottom, you have non-steroidal anti-inflammatory drugs and topical analgesics. They are not reaching the blue line, the minimal clinically important difference level. But some of the other treatments, for example, exercise, land exercise, walking in particular, at the top of this graph, you'll see walking has significant benefits over the minimal clinically important differences. So these give us a lot of food for thought in terms of how we manage osteoarthritis and what we say to patients in terms of what they should be doing in terms of physical activity and exercise. So for osteoarthritis, exercise is beneficial. Moderate intensity exercises are highly recommended for patients with osteoarthritis. Now, of course, if those patients have had a history of joint injuries and if they've participated in high intensity, high impact, I should say, exercises, maybe those exercises are not suitable for people who have had ACL rupture or meniscal tears. So every person needs to try the sports that they enjoy and see for themselves what suits them best. So it's different for every person. Benefits of exercise are very, very significant. Of course, neuromuscular exercise, as shown here on the left-hand side in a very elegant review by Eva Roos and Stefan Lohmander, is well established as a way to support the joints of people with osteoarthritis. And on the right, you see broader impacts of exercise. So it's not just about joints, and this is absolutely crucial. Exercise impacts on pancreatic function, on cardiovascular health. It increases beta cell function in the pancreas. It supports the heart and the blood vessels. It increases insulin sensitivity, triglyceride mobilization, adipose tissue, efficiency of adipose tissue resource burning. Muscle mass increases sensitivity, insulin sensitivity of muscle, increases glucose uptake in muscle, so the glucose consumed in our diet can be more efficiently handled and stored. It increases mitochondrial mitophagy, which is a good thing for muscle. It increases fat oxidation, which is effectively burning fat. And it reduces lipotoxicity from lipids. It has impacts on the cardiovascular system, on the vessels themselves. At the whole body level, it increases aerobic capacity, insulin sensitivity, and overall benefits for health are very significant. Reducing insulin resistance, reducing the chances of developing type 2 diabetes, reducing the risk of cardiovascular disease and metabolic syndrome. And of course, it helps us manage our weight and keep obesity down. And ultimately, it has impacts on not just these morbidities, but mortality and how long we live. So these are really important. And this was just published a few days ago in Nature. Exercise is now believed to generate immune cells in bone. So exercise not just has impacts on those soft tissues and that I mentioned in the previous slide. Exercise stimulates bone cells. That stimulation of bone causes differentiation of stem cells and stimulation of the common lymphoid progenitors, which can then differentiate into immune cells. Those are the lymphocytes that can fight disease, bacterial, opportunistic infectious diseases, and also viral diseases. So exercise is also another way to deal with common pandemics such as COVID-19. There is good evidence that a lot of the people who have had the worst symptoms are obese, overweight, have metabolic syndrome, diabetes, etc. And those are the people who are getting vaccinated. So it's clear that if you're able to exercise, you're going to have an immune function boost as well. And those of you who attended the last OAFI Patient Congress, you will have heard this lovely presentation by Professor Lee Callahan from UNC, talking about the Arthritis Foundation's Walk with Ease program. They have a self-paced 6-week program with very, very comprehensive data on their website and guidebooks to lead and guide the patients. They can be done individually or with others. Spring is approaching and we're coming out of lockdown, and this is a great time to be going out there. You know, very, very nice, especially if you happen to live in Spain, whether it's warmer climate, to get out there and enjoy the outdoors and of course, maintaining physical distancing from others, but get fit, getting to exercise more. Here are my final conclusions. Regular physical activity has been suggested to have preventive and therapeutic benefits for osteoarthritis. However, evidence of whether exercise and which type of exercise constitutes a benefit or a risk is still debatable in some areas, and which types of sports are recommended still needs to be researched. So we need to fill in these gaps, and we need to get more interdisciplinary research done in this area and gather more evidence and build the best evidence base possible. And in the meantime, people should continue to use common sense. Moderate exercise is the best advice, and avoiding high impact exercise if their symptoms worsen, or if they should listen to their bodies and listen to their joints and take care of themselves. Thank you very much for the opportunity to speak to you, and looking forward to the discussion later.
Okay, Professor Ali, thank you very much for your excellent presentation. Clear and magistral, state of the art, fantastic. I think for introducing in all of our symposium, I think it's excellent. Okay, it's an excellent revision about the benefits of the physical activity in the field of osteoarthritis. No, I have two questions. Do you think that it's very important in order to avoid the problem of osteoarthritis? I think is one important issue is to start the prevention when you are children. No, I think this is one important issue. What do you think about that? Ali.
That's a great question. Thank you, Giuseppe. A few months ago, I started writing an article for a journal called Frontiers for Young Minds. It's actually a journal for teenagers and middle school and high school children. And we basically wrote a core concept paper. What is osteoarthritis? What are the risk factors? And how do you prevent osteoarthritis? So to answer your question, absolutely, we need to be educating youngsters, children, teenagers, adolescents about behaviors, risks. So being a couch potato is not a good idea. And of course, a lot of the children, unfortunately, have had to behave like couch potatoes in the last 12 months because of the pandemic. But gradually, as things are lifted and spring is approaching, I think we need to get them more active. Schools need to get involved in this as well, because physical activity is not just for joints, it's for many other body systems. We need to get children better educated. Now, this paper that I mentioned to you, it wasn't found to be acceptable because we were writing it at a very high level. And the journal basically said, you need to develop better skills to use the language that children can understand. So that's part of what I would call lifelong learning. I may be professor of this or that, but ultimately I need to develop the skills to be able to communicate my very high level science to high school children. That is the age group we need to influence, not just for prevention of osteoarthritis, for prevention of all chronic diseases. And I think all of us have to play our part. It's great to see OAFI being so strategically focused on prevention of osteoarthritis in women and in sports, men and women. And might I suggest, Giuseppe, maybe we should work together on children and adolescents as well. That really is they will be the future population with osteoarthritis, with a greater burden of osteoarthritis if we fail in our task of educating properly.
I agree with you. We are working together always, ORC and OAFI, we are good partnership, and I completely agree with you, and we can work, continue to work in this issue, in children to prevent. I think it's a very important issue. No? And the second question, you explained very well about the importance of the exercise in the patients with OA, no? Because sometimes the problem that we know with patients with OA that they don't move, no? Because they have pain, no? You present very well this data. Some, practical issues. in your experience, what, according to the revision that you make very well, is that how times per week, should be at least, positive for the OA, what kind of exercise, what do you recommend for our people that, from osteoarthritis, they are listening to you? Some recommendation.
Sure, thank you. Well, that's a great question, Josep. I would say I'd like to use myself, with your permission, I'd like to use myself as an example, please. So I have osteoarthritis in my left knee. It is painful. It is Kallgren-Lorentz 2/3, and it has progressed quite significantly over the last few years. It was first diagnosed just over 10 years ago. Okay, 11 years ago exactly. So what do? I go out, I still jog and I still walk. I have to admit, when I go jogging or walking, I do at least 10 to 12, sometimes 14 kilometers. I have to say, every time the first 1 or 2 kilometers is painful. There is a period, there's that initial first 7, 10, 14 minutes, 15 minutes, where the pain levels are quite high. And then, as you get into the exercise, it starts to ease. And what I find is that the benefits I gain last for a few days. So patients are going to complain about pain. There's absolutely no question about it. If you have osteoarthritis and you exercise and you walk, you are going to experience pain, and you may experience periods of more acute pain. Again, I'm talking about my own perspective, but I can tell you the benefits are far greater if you do exercise and do experience that short period of pain. The benefits for pain control and ease of function of the joint are greater compared to no exercise at all. If you're simply sitting immobile with no physical activity, the symptoms of pain and the feeling of hopelessness, the mental strain of that is far greater. So I would say, get out there and listen to your body, exercise, and build. The Walk With Ease program has got very nice guidance on how to build up. So don't start with, like me, with 10 to 12 kilometers. No, start a little bit at a time. Start with 1 or 2 kilometers close to home, and then gradually you build on that with your friends, with your family members, by the beach. You have the Mediterranean, enjoy it. I think it's really context and environment dependent, and it doesn't happen overnight. I think it needs hard work, dedication, and you just need to find the program, stick to it, and listen to your body and see how your joints feel. So every patient will be slightly different.
Thank you, Ali. Thank you for your good answers. I completely agree with you. And I really appreciate your time. Stay with, with OAFI. It's a great pleasure. Thank you again. And we are happy that you collaborate together. And, and I appreciate your talk today in our symposium.
Thank you for the invitation, Josep. And look forward to seeing you soon.
Thank you. And, we can say in Spanish is that el doctor Ali Mogasheri comenta muy importante que la prevención debe empezar desde la infancia. Yo creo que es un tema muy importante para que nuestros niños y niñas el día de mañana pues puedan tener una salud articular y no acaben en prótesis. Por lo tanto, muy importante empezar. Estos son los temas que ha sacado el doctor Ali Mogasheri, y sobre todo ha sacado un punto muy importante, que es la importancia de la actividad física en la gente que tiene artrosis. En lugar de quedarte en casa, no moverte, es al contrario. Te has de mover, hacer una actividad física, has de andar, hay un montón de actividades, y lo ha explicado muy bien. Empezar poco a poco, pero es muy importante que la actividad física mejora muchísimo la artrosis. Bueno, Ricardo, como diríamos, devolvemos conexión, Ricardo, para continuar con el congreso que estamos haciendo articulando el deporte OAFI, el Comité Olímpico Español y la Fundación Atlético de Madrid y los servicios médicos del Atlético de Madrid. Adelante, Ricardo.
Muchas gracias, doctor Vergés, doctor Josep Vergés. Muchas gracias, profesor Mogasheri, presidente de OAFI. Han visto la investigación, lo que se está cociendo en el mundo de la artrosis. Ahí va a estar OAFI, evidentemente. OAFI es una de las organizaciones que está colaborando, trabajando codo con codo con OAFI, o OAFI con OAFI, es decir, tanto monta tanto en este caso. Nos hemos puesto en marcha, tenemos 5 días apasionantes por delante, tenemos un montón de invitados, unas 20 mesas aproximadamente. Están todos ustedes invitados, invitadas a disfrutarlo y a participar con nosotros. Así que gracias, no se muevan porque enseguida regresamos. Primer simposium articulando el deporte con OAFI, con el Comité Olímpico Español, con la Fundación del Club Atlético de Madrid. Bienvenidos.